Hi there. This is Mitch Stripling, and this is my fourth and final talk in my lecture about public health emergency management. I talked about the history, the current structures of it, dug into the COVID response, and I want to spend a little time now talking about public health ethics and why they are so important in a disaster and what we can do about them. And so what I want to note first off is that the medical community, the public health community, has a strong set of ethical guidelines already in place, right? Doctors are committed to providing patients the best care they have. Public health professionals are committed to help their community. The thing is that what happens in an emergency is that we assume that there are going to be scarce resources. You've heard about this in terms of ventilators in Italy or Texas, people wondering if they're going to run out of healthcare equipment. But it's also true about staff and space, even more profoundly. Will we have enough places for patients to go, enough ICU beds? Will we have enough staff to take care of them? And what that does is it creates this idea that there's going to be a conflict between the needs of a particular patient and the needs of public health writ large. This is the dilemma that you keep reading about. It's something that was in the paper of mine and Dr. Pascoe's that I gave you to read. And it's the idea that you're going to have a doctor, and that doctor is going to be faced with this terrible choice where they have two patients, one ventilator, and they're going to need to give the ventilator either to patient A or patient B. And the question is, well, how do they decide to do? They can no longer think about the optimal patient's care because the needs of the many, the needs of all the people that are impacted by the response are jutting in. How do they do that? So what I'm going to do first is talk about the crisis standards of care framework that is used in ASPR in HHS. We talked about that before. It's based on initial guidance from the Institute of Medicine, now the National Academy of Medicine, that came out in 2012. And so let's kind of look at what that is. A crisis standards of care is a substantial change in healthcare operations and the usual level of care made possible by some kind of pervasive disaster. So that could be a rapid disaster, like in an earthquake. Suddenly your beds are overwhelmed by people with injuries, or in a pandemic, as we've seen over weeks and weeks, your bed counts kind of go up and up until they overwhelm you. And the question is, when you do that, how do you decide to trigger a crisis standards of care, knowing that it might mean different changes to patient care, right? You might either not give someone a ventilator, for example, because based on triage, you feel like they're not going to have a good enough medical outcome. You're going to sort of make these sort of terrible choices. And the question is, how do you make them? So what crisis standards of care does is it gives a planning framework that's based on a certain set of ethical principles, the laws, the importance of providers themselves, and some steps that are in place to help you provide care equitably under these conditions. Because what you don't want is for a provider, all of these different providers, to be using different sets of principles that are ad hoc. Because one of the worst things we found in crisis standards of care is that if the public doesn't understand why you're deciding, if you're not transparent about how it works, and if the ethical principles underlying it don't seem like moral to people, it's going to be sort of terrible. So you really need to have thought about this beforehand. Crisis standards of care are based on how are you fair to everybody? How do you make sure you provide the care you can? How do you steward resources well so you don't want to waste resources? This goes back to the mask thing, right? If you need to make sure that all of your patients can have masks, you need to steward those resources. You need to make sure that you're not wasting them on people that don't really need them. You're transparent with the public. You're consistent with everybody. You're accountable. That is, if somebody goes off the guidelines, you need to hold them to account, for instance, through a medical review board or something like that. And what you do essentially in crisis standards of care, and I don't know how well you can see this, but you set up a set of indicators and triggers that are fair to note as you get to a certain part of resource scarcity, whether that's ED rooms, whether that is negative pressure rooms, something about some kind of supply that you're going to run out of, staff supplies. You set key triggers, and those triggers are tied to strategies. And it's not like you, right off the bat, you come and you say, well, oh my gosh, we're starting to run out of stuff. let's start taking ventilators away from people, right? You use a whole set of practices first. You want to get rid of the non-urgent cases. You want to be adaptable. You want to see if there are ways you can use equipment differently. So we saw in COVID people 3D printing sort of ventilator accessories, working on how to use one ventilator for two patients, that kind of stuff. So you want to be resourceful, and also you want to share resources. You want to make sure that if you have resources in hospital A, they move over to hospital B, so you can sort of balance these things out. And this is all based on a set of underlying ethical principles. We know, and this is from the Institute of Medicine, groups that are most at risk during a disaster are most at risk before a disaster are most vulnerable during a disaster. So you want to make sure that you can give them equivalent resources. And also, some healthcare professionals are so worried that they're going to be in this position and they're going to have to let their ethical principles go, right? That they're going to be doing first come, first serve, giving things to anybody who's there, that they won't be providing optimal care for patients. It's something that doctors really worry about. So do EMS technicians. People with an underlying duty to care want to make sure they can exercise that duty to care well. And so they're really worried about the ethical guidelines for this kind of situation. And that's why there's been so much work on it. CDC, HHS, everybody's done so much work on this question of these crisis standards of care. When you get to this moment of scarcity, how do you address that moment of scarcity? The thing I want to give you today, and I think this is a little difficult for emergency managers because we don't go in this direction a lot, but I think we've seen in COVID how important it is. The thing that I want to sort of talk to you about is that there's a reason that we think this way. And the reason has to do with the underlying ethical principles that we rely on and sort of underpin our procedures. We are really focused on the crisis standards of care because our ethics in disasters are underpinned by this thing called utilitarianism. It's actually called out in the CDC's guidance on pandemics. Utilitarianism is a moral principle that comes up a lot in disasters, which is based on the idea that you have to improve the good things that are there in the world and decrease the bad things. In a disaster, this is often expressed as doing the best you can for the many, right? You want to save as many lives as possible. And sometimes that means that you will do things that do not benefit a few. This utilitarianism concept is based on something called the state of nature, which was come up with by this philosopher Thomas Hobbes. This other guy, John Locke, kind of built on it. The state of nature is this idea of the chaos that existed before civilization. And in Hobbes's view, people were all trying to kill each other during that, and civilization are the set of structures you put on top of that to make sure people don't kill each other. And so the reason you have utilitarianism as an idea is because if you don't sort of defend civilization, if you don't do the good for the greatest number and allow the acceptable sacrifice of some others, you're going to descend back into chaos. It's this action movie idea of disasters that we've got baked in our heads about what happens to society when a disaster comes. And what that leads us to is that we start to think of these disaster questions like trolley problems. And if you've never heard of what a trolley problem is, there's a great episode of that show, The Good Place, about this, which is a trolley problem is basically like an ethical conundrum. And the classic one goes like this. So you are standing at a switch, a railroad switch, and you see a trolley coming down a track. And the trolley is headed towards 5 people that don't see the trolley coming. And if you let the trolley go, it's going to kill those 5 people. And if you pull the switch, the trolley is going to go onto another track and it's going to kill a person. And it's going to be sort of your fault that that person gets killed. But overall, from a utilitarian standpoint, it's better because fewer people are going to die. Utilitarianism is about the ends, right? What's the end of what happens? It's different than some other moral frameworks, which are about you personally. If you were this guy, Immanuel Kant, and I know this is getting wonky, so forgive me, he would say, well, you shouldn't pull the lever because you can't kill anybody. The ends don't matter so much as your decision points. There's another version of the trolley problem, which is called the fat man problem, which I think is probably a really offensive way to phrase it, but that's what it's called classically. And in that idea, you are standing on top of a bridge with a person who weighs significantly more than you do. Same thing. The trolley is coming towards these 5 people. Now, you are little enough that you're not going to stop the trolley, but the person next to you is big enough to stop the trolley. So the choice is, do you throw that person in front of the trolley killing that person, but stopping the trolley, or do you let it go? Philosophers, they really enjoy their deep, really esoteric, kind of crazy logic problems. But the point of talking about them is that in a trolley problem, terrible choices are necessary. And we assume that those terrible choices are necessary because we're in a confined system. I'm a doctor. I've got a ventilator. I've got 2 patients. I've got to make a choice. Utilitarianism is my best guide for that choice. So what's the problem with that? There's an issue with it for kind of 2 reasons. Reason 1 is that we know disasters don't actually function like that. We have really good disaster sociology for the past 100 years, from Rebecca Solnit, who's written about it recently, to all the way back to early disaster sociologists, Quarantelli, and even going back to other military theorists like Clausewitz, that's not what people do when they're in extreme situations. The first thing people do is they try to work together with each other. They work cooperatively. So this idea that there's this veneer of terror underneath society isn't true in disasters. But in our imaginations, based on the action movies and stories we hear about it and people telling us, like, our brains try and convince us it's true. So we spend a lot of time on crisis standards of care planning, which assumes scarcity, and we don't spend a lot of time making sure that scarcity doesn't happen, building out structures that will help us to cooperate with each other, making sure that that doctor is never put in that situation where they have a ventilator. Yes, we do some things. We've got EMAC. We have great, that's the Emergency Management Assistant Compact to send resources from state to state. But our focus is on scarcity. Our focus isn't on cooperation because of these utilitarian ideas. And you see that when you read all the federal planning, they're all based on this idea that we're going to be in scarce resources and we're going to compete for these resources. My point is, there are a couple of bad things that leads to. It leads to things like in COVID, we've called people essential workers, the grocery store workers, home health aides. They're essential. They're keeping society going. And we've asked them to keep going without giving them substantial support. Because somewhere in the back of our minds, utilitarian is saying, well, some workers need to be sacrificed. And maybe that sacrifice is necessary to keep all of society going. That's a very utilitarian idea. Similarly, some of the militarized responses we saw, like the Javits Center response, where we're building up this other response structure, is utilitarian because what we're saying is we know that there's this competitive health system. We've got to build something outside of it to take on more patients. The point of this is these things make sense if you're using disaster movie logic, but if you're using kind of the cooperative thing that really happens in a disaster, it's a little weird. It's like, why are we so focused on scarcity and not on cooperation? And it's weirder when you look at how other places in the world are looking at these problems. They are not as focused on scarcity. If you look at Jacinda Ardern, I think in New Zealand, the president there, she is very focused on we are all going to care for each other. In South Africa, the ethical framework at play there is called Ubuntu. And in Ubuntu, the primary idea is that a person is a person through other persons. Your worth is the same as the worth of all of these other people. And so procedurally, you can never assume that scarcity is going to happen, because it is your job as a person to give every single resource you can to make sure that this other person is never in a system of scarcity. There's this other principle from Buddhist ethics called k-ethics, which is that what's really heroic is not sort of the doctor who has to make this terrible choice. Let's stop saying that's who the hero is. The hero is really the person who is giving the day-to-day care that's making the situation possible. So the folks like the home health aides, the grocery store workers, the nurses, it's not enough just to call them essential. They are really the ones who deserve the most resources. You would never give resources to an outside response like the Javits Center framework before you had increased all of their pay and benefits, right? To reach the worth of the job they're doing. And that's something that they've done in other countries during COVID. They've taken these sort of essential workers. They haven't just given them hazard pay. They've sort of redone the social contract with them, right? So they're more essential or truly essential part of the response. So what I'm trying to say is that our procedures that public health is really grounded in this sort of ethical principles. And doctors, public health practitioners really want to do good for everybody. But the logic, the disaster logic that we're putting on top of that is based on these utilitarian frameworks of scarcity. And that's what our federal planning has been primarily based on. When North Carolina tried to write a crisis standards of care framework, for example, they rejected having solidarity in it because they said solidarity was not an American value. This idea that we will all stand together wasn't an American value. And so therefore, North Carolina kind of stripped that idea out of their crisis standards of care framework and leaned more heavily into this idea of competitive scarcity. Hospitals will be competing with resources, competing against each other for resources. Therefore, we'll have scarcity. Therefore, we've got to focus on the decision. But the real ethical thing to do is to go back to that first principle and say, why are we assuming hospitals are going to compete with each other? In other countries, they don't have to here. Let's work on, in a public health emergency response, changing that underlying framework. Let's build it based on Ubuntu so that we all care about each other's humanity. Let's surge care ethics. So we're really taking care of the people we're relying on to take care of us. And that gives us sort of a new way to look at public health ethics. And this is the way a lot of bioethicists are kind of leaning. Matt Wynea in Colorado has written about this. The paper that Dr. Pascoe and I put out is kind of pushing for this. And you're seeing it more and more that we need to stand in solidarity. Because in COVID, very clearly, we saw people do that, right? People immediately started making masks for each other. They started giving food to healthcare workers. People were trying to help. And if we put in place a set of ethical frameworks that takes that desire to try and help and builds on it, that's a lot more powerful than taking a set of ethical frameworks that assumes we've got what we got and we ain't getting any more and that we're going to fight each other for it. And so we've got to put rules in place for that fighting. Better to sort of surge the solidarity from the ground up, expand the pie, as it were, than assume the pie is going to be small and stop each other from fighting over slices. That's not to say you're never going to have a doctor in that situation having to choose between one ventilator and two patients. I'm not saying it's not possible. It could certainly happen, but it doesn't need to overcome our entire imagination. We need to kind of shrink that in terms of our thinking and think more about how to work in solidarity. And this is already starting to happen. So Minnesota, for example, in 2020 updated their crisis standards of care framework. And what they said was that solidarity was a first principle. Before we would focus on these crisis standards of care, first we're going to look at sharing how we all stand in solidarity with each other. We're going to build up that solidarity first. Governor Cuomo in New York offered to ship and did ship the ventilators that were in New York to other folks as surge happened, right? So through partnering, we're starting to say, we know we have a surge here. We're going to put resources here, and then those are going to be shared from jurisdiction to jurisdiction in the country. And even in New York City, where the hospitals are famously competitive with each other, they put in a network of care in place during COVID. Been trying to do it for 10 years, never really happened. Finally, during COVID, they came together. And so when Elmhurst Hospital in Queens started inching close to this idea of resource scarcity, they were able to offload their folks to other hospital beds and to Javits Center, which became part of this system. So I guess what I'm saying is we humans in disasters, we do share and we reach out. We know that. But the ethics that we've written into our procedures and our plans don't always account for that. They're sometimes based on this kind of scarcity logic where we assume that what we've got in the world is what we got. We ain't getting anymore. But we know that in disasters, people do contribute more. So what I'm saying is that we can and should refocus our ethical plans and procedures so that they're not as baked on utilitarian principles. They're not as focused on these questions of scarcity. They are focused, though, on how we surge on the cooperation and solidarity that people will feel in disasters and how we use that to really honor the frontline workers that we need and giving them sort of both the label of heroes, right, which is where it really belongs, and the resources that we use for other things like these big militarized responses. The resources that we should be putting into day-to-day care we sometimes put into these other kind of shiny response structures. And instead, let's just surge where the care is already happening, bring the community solidarity in there. And what sort of research in other countries have shown us is that's actually a more functional response system, because the ethics are it's based on don't have scarcity baked into them. They have solidarity baked into them. And that level of cooperation is kind of the rising tide that lifts all boats. So thanks for that little wonky breakdown into ethics. I hope that you'll take these ethical points seriously and take them with you into your emergency management career, because we are faced with a lot of tough choices. And you always need to think not just what's my best option here, but kind of what's behind the curtain. What are the reasons I'm being backed into this ethical corner? And how do we help the community writ large bring its power to bear in these situations? So this has been my probably too long lecture on public health emergency management. Thanks everybody for your attention. Again, I'm around if you have any questions or thoughts about it, and I appreciate your time. Good luck with the rest of the course.